So thank you so much for everyone who's joining us from all over the world. And tonight's topic is exploring the barriers to prescribing of medical cannabis in children with refractory epilepsy in the UK. And I'm just going to start with a few slides about the society. So as you probably know, I'm Dr. Dani Gordon. I'm the Vice Chair of the Medical Cannabis Clinicians Society. I'm actually an adult prescriber for medical cannabis, so I have many years experience with adults, not with children, which is why we have our excellent community of international pediatric experts with us today. And as you probably also know, the MCCS is an independent body of expert physician-led nonprofit group that we specialize in, focus on the education of clinicians that are interested in prescribing medical cannabis or interested in just having more awareness about medical cannabis as a medication option for their patients. And getting my buttons down here. There we go. In the UK, there are currently around 150 children who currently use whole plant medical cannabis for their intractable epilepsy, but there are many more who could benefit from the therapy who do not have any access yet. And the problem is there's only one prescriber in the UK for all of these children, and he's currently not able to take on any new patients. So this has reached a critical point in the UK. They have no one to continue helping them to access their medicine. And although this medicine is not a cure-all and it's not for everybody, it is a life-saving and life-changing medication for many of these children. And without getting more pediatricians interested and curious about prescribing, we are in a very bad position here in the UK. And the British Paediatric Neurology Association has recently published guidelines that were very negative towards medical cannabis, meaning full plant extract medical cannabis that wasn't Epidiolex. And we as a society, we fundamentally differ in our opinions. And along with drug science, we've published a commentary in response to the BPNA guidelines and hoping that it will open a dialogue so we can really talk about how we can help these children get access to this medication and just increase awareness and understanding around this medication option, and the fact that it's actually a very safe option. So that is where we're at. And with that, I would like to introduce our lovely and excellent panelists who have kindly joined us from all corners of the globe. And as a group, they have prescribed, even some of them individually, many thousands of patients in the pediatric age group, most of whom have childhood epilepsies. So first we have Dr. JP Appendino, and he's a pediatric neurologist and epileptologist, and he is currently located in the Alberta Children's Hospital. And he's also a clinical professor in the Department of Pediatrics. And then we have Dr. Evan Lewis, who is the medical director of the Neurology Center of Toronto, and he's also the VP of psychedelic neurology at a company called Numinous, which is very interesting to me. And then we have Dr. Bonni Goldstein, who her reputation really precedes her. She is a multi-book author on the topic of medical cannabis. She is a pediatrician and she's the director of the Canna Centers, and she's also treated thousands of patients with medical cannabis in the pediatric age group. And then we have Dr. Jane Hailey, who is a UK trained pediatrician. She currently is working in Canada for many decades, and she is currently the only prescribing pediatrician in British Columbia, Canada. She's also an associate professor at the University of British Columbia, and we really thank her for joining us. And she's, I guess, really the only UK transplant. She's gone the other way as me. And I am a cannabinoid and integrated medicine specialist, originally practicing in Canada and more recently coming back to the UK. And that's us. So with that, I'm going to get out of these slides, which I'm really having trouble with controlling for some reason. Okay, there we go. So, and I'm just going to pull up this Q&A. So if you have questions, I'm going to keep an eye on the Q&A as we keep going here, and I'll do my best to get to everyone's questions. So I'll just ask everyone to kind of, all the panelists, please jump in if someone is saying something that is kind of making you think of a case that's similar, or you have something to add. We just want it to be as collaborative as possible, because it's not very often that we get so many experts in one room from so many different places. So thank you all again. And with that, I'm going to open with Dr. Evan Lewis, who would like to share a case study with one of his own patients, a 2-year-old girl who he saw in his practice. And I'll let you take it from there, Evan.
Great. Thanks so much, Dani, and pleasure to be here tonight, and welcome to everybody who's listening in. Hopefully we can have a great discussion tonight and touch on some really important topics around here that Dani's pointed out. So I'm just going to share my screen here. I thought it might be nice to start this this evening for those who are listening where it's evening, and daytime and afternoon for those who listen where it's the afternoon, just to run through a case that I saw in my practice that I think is a really important case to share with everybody to help set the stage here for some of the issues that are arising not only in the UK, but are present in Canada, present in the US and other areas in the world that are working with cannabis as a treatment for various disorders, especially for epilepsy. So this is Quinn, and Quinn, at the time that I first saw her, as a 2-year-old little girl, and she was totally, completely developmentally normal up to 2 years of age, and had an explosive onset of seizures. So began to have very significant, high number of seizures during the day and evening. You know, we did all of the regular stuff that we do in pediatric neurology and epilepsy in terms of assessing where the seizures are coming from and starting on the correct medications. And we managed to get a hold of the daytime seizures, but not the evening seizures. And she continued to have a high frequency of evening seizures. Now, when this happens in young children, for those that may not know, and kind of, you know, continues, what's really happening is when the seizures are not happening, the electrical activity in the brain is quite abnormal. So the brain, you know, might have developed well up until that point, but starts to develop abnormally or starts to regress. And you see this in young kids as a loss of skill. So as I mentioned, she was a developmentally normal little girl walking normally. And you can see here, she can hardly even stand in one place. She lost the ability to use her hands well. She lost the ability of some of her speech. Her cognition was suffering. And so she was really going downhill. Now, in most cases, when we have a child like this, that is just a progressive kind of continuing course when you can't get a hold of seizures. And some of these children end up quite affected, both from a cognitive point of view and a physical point of view. And that's because the EEG, the measure of the electrical activity in the brain, tends to look like this at all times. And if anybody doesn't know EEGs, a lot of big, high squiggly lines with sharp points to them is not good. And that's Quinn's mom there, Carrie. So after trying the few of the traditional standard medications we use for epilepsy, we had a long discussion about cannabis, and together decided to try cannabis for Quinn at that time. And literally within a few days, her seizures stopped, and within about 3 weeks, I actually think the EEG was 6 weeks afterwards, you can see a complete normalization of the EEG. Now, that doesn't happen that often in pediatric epilepsy when it's this bad. There are very few conditions where we use the traditional medications where that happens. I'm not saying that, again, this is for everybody, but I'm just saying, the rarity of this is not common. The fact that this happened with cannabis was quite striking for me at the time, as this was one of my my much earlier children that I worked with. And then even so if you get a hold of that EEG, as I mentioned, and you kind of stabilize that electrical activity, you also stabilize the development of the brain. It starts to work properly again. And that's exactly what happened. So you can see she went from, on the left, pre-cannabis to post-cannabis, functioning like a very normally developed, almost 3-year-old at this time. So she went 12 months seizure-free with a dose of focused CBD dose of 8 milligrams per kilogram per day. And she was doing great. But then, unfortunately, seizures broke through at the 12 months point, and she started to have the seizures again. And recurrence of all those deficits happened. The EEG became abnormal again. And we tried some various things. We increased the CBD really high. That really didn't help. We tried this cannabis receptor reboot and tried to kind of like pull it off, put it back on. That didn't help. And as my understanding of the endocannabinoid system grew, I think of the endocannabinoid system as a balancing system in the brain. And what I thought at that point in time was, okay, her endocannabinoid system was dysregulated, and we managed to regulate it with the CBD, but maybe we pushed things too far in the opposite direction, if you can think of it as a balancing scale. So what we did was we we did something pretty interesting. So there's just her EEG again, kind of becoming abnormal again. And what we decided to do was to start to add THC. And we did this in varying small amounts. And the idea was to maybe bring that balance back in the direction, because maybe we pushed it too far with the action of CBD. And we know CBD and THC work in opposition to each other, especially in the brain. And lo and behold, that worked perfectly. And it was almost, again, overnight, her seizure stopped again. After a period of time, her neurologic deficits, which had reappeared, normalized. And mom even said at the time she was even better than she was before. So fascinating. You know, and there we go. EEG before the add-on THC, and then EEG afterwards, kind of renormalizing. And Quinn has done great since then. She broke through again at a little point. We added a little bit of THC, and she's been seizure-free now for over 12 months. She's a twin. She's developed exactly equivalent to her twin. She's you know, doing great. We actually published her case amongst 4 others in a recent article that came out to show that in some situations in epilepsy, the addition of THC actually works, and is actually the only thing that works in those cases, and not just focused CBD treatment. So it just opens up a real interesting concept here. So much to learn, so much we don't know yet about this stuff, and especially in the context of epilepsy, and thought that would be nice to kind of set the stage here for everybody to talk about this and beyond.
And Evan, do you mind sharing that excellent case series as well with the group in the chat at the end, so
Sure.
people might be able to access that? Because I think, you know, that opens up a really interesting discussion point, and I'm sure as some of the other speakers may have had experience with THC in children. And was that your first time adding THC in a pediatric case, Evan?
So I would say it was in such a deliberate fashion. So in Canada, we at that time especially, you know, only had access to oils which only contained CBD. So we only had CBD-rich extracts, which had a proportion of THC in them. Now there's some more products on the market, so we can actually get purified CBD products that are similar to Epidiolex or Charlotte's Web. So at that time, yeah, that was my first kind of directed case. Now I have a whole phased protocol that we've developed at my clinic that starts in a progressive kind of stepwise fashion, you know, focusing on CBD, then adding THC, then looking at some of the other minor cannabinoids and terpenes as well. But following that patient along and seeing at what point in the phase do they, in the phase protocol, do they respond.
Fantastic. Anyone else want to chime in with any similar experiences?
Well, I take care of many children who use both high ratio CBD oils. And if anybody is unclear what that means, it means there's the proportion of CBD is much higher than THC. If you look at some of the research that's been published, like out of Israel, they use a 20-to-1 ratio. That's fairly common. The Charlotte's Web oil that's available here in the United States runs about a 25 or 27-to-1 ratio. So there is going to be a small amount of THC in that product that you have to be aware of. But in general, you know, the child's not going to be impaired when you start at a low dose and titrate up in a, you know, with a protocol. But of course, you have to be aware of that. But I have many patients where back when I first started doing this, all we had was, you know, CBD and THC. We added in THC to lower that ratio. And everybody used to say, well, what's the ratio for your child? Maybe that'll match my child. And it really does seem to be individual. And certainly starting, like Dr. Lewis said, you know, low dose and titrating up, and certainly not hitting what I named the ceiling dose, which is where you see impairment from the drug. You certainly don't want to do that. You want to keep the child. The whole goal is to get the child better and functioning and hopefully into school and learning. So you really have to be careful with the THC dosing, but with the proper products that allow you to measure small amounts accurately, you can do this. Now, I also want to add in that in addition to CBD and THC, we've been using THCA for quite some time here in California. And then just recently, with the publication of a paper earlier this year that documented some anticonvulsant activity of CBDA, just this year, 2021, I've been using CBDA quite a bit. And there seems to be some maybe additive with CBD or, I don't think it's been investigated enough. So we certainly have a lot of questions about it still. Certainly doesn't have the amount of research behind it as CBD does. But certainly Cbda allows me to treat patients without having to worry about impairment. You can really escalate the dose. In fact, I think somebody right now, I have them on close to 400 milligrams a day of Cbda that added an extra about 75% reduction of seizures. He was kind of what I would call a partial responder of CBD. And so when we added Cbda, we got much better. So there's lots of choices within the cannabis realm. And I think that my colleagues who are nodding along with me, I think clearly all of us are very careful about side effects and the side effect profile, which we know is pretty reasonable. And certainly looking at other seizure medications. This is a medication, including THC, which has this bad rap as the, bad cannabinoid. It is not the same as recreational use. And I think it behooves all of us to separate out recreational from medical use when it comes to THC. And Dr. Lewis's case is a clear representation of how THC can be so beneficial for a child who's suffering, where CBD doesn't do everything you need it to do.
Thank you. And as far as side effect profiles go, now I know many of you also use, as epileptologists, also use other anti-epileptic medications. How do you find it compares with side effect profiles in terms of things like not only intoxication, this idea of intoxication, but cognitive side effects, behavioral side effects? Do you have those concerns ever with other medications as well?
May I make a comment? Still with the previous THC component. In the province I work in Canada, we try to prescribe the higher concentration of CBD versus THC. And the rationality behind that is that there is not much research done in the clinical application and the clinical results long-term of the THC. Therefore, we try to avoid as much possible the content of THC in our formulations. And it is known that the THC component is the one that has the psychedelic type of effect. But again, the lower concentration it has is usually 20:1. It's well tolerated, but higher concentration, higher ratios, 10:10 or something like that, we tend to avoid, particularly in younger children, because we don't know what the effect is. So, and here is where the criticism to research not criticism, but in the good sense, that where the avenue of further research and further learning should be focused. We don't know how the long-term impact of the chronic use of THC in a developing brain may affect. And that's why many of pediatricians or colleagues may feel a little bit hesitant to use THC. And so it's also for people that is attending that it's okay to consider perhaps a small proportion of THC in the concentration, but knowing that is not as well known as the CBD effect in so far the epilepsy management. That's a comment that I just wanted to be clear, that we don't know if it is as not detrimental, the use long term just yet. That's what. Yeah, sorry about that, Jane.
No,
yeah,
sorry, I didn't want to interrupt. I just wanted to say that I have had great success with THC. I've been referred many children who have self-injurious behavior, who are in homes, who need round-the-clock caregivers. I've learned that it's better to use the pure THC and not the combination blends. And I've had so much success with the THC that I usually tell patients straight off, even the kids with autism and epilepsy and all of those everything else I see kids for is that I will probably add some THC at some point. But now that I've learned through advice of my colleagues in Canada, the correct dosing and how to do it, it's been overwhelming and extraordinary. So I am a great component of using it, and it's worked for me or for the kids.
One added comment too is that now that I have patients that I've been following, so for instance, this one little boy I wrote about in my book, age 4, when I first met with him with intractable seizures and autism, the CBD, you know, kind of, again, high ratio CBD oils did help significantly with his epilepsy, but it actually aggravated his autism. And so we added in THC to kind of added balance. And we know now that there's numerous studies that show that children with autism seem to have what appears to be what we call endocannabinoid deficiency with low levels of anandamide. THC is the compound that mostly is the closest cannabinoid from the plant that mimics anandamide and likely replaces that. And again, we can't really go into a child's brain to see exactly what's happening. We have EEG and we have CT and MRI and those kinds of things, but really on a cellular level, it's very hard to know. But I'll share with you, this child's been my patient since age 4. He's now in 6th grade, 11 years old. He is reading, writing, doing math, winning award for self-control and best attendance. And so what I say to people is, if there is a detrimental effect, and I'll tell you, I worry that maybe when this child's 22, he'll have off the chain anxiety or something, because we know that, again, that overuse during teenage years can lead to some issues later on in life. And it's hard to say in which child and how much they used and what they were using. But I think when you have that balance of CBD in there, helping to, as Dr. Lewis said, you know, they kind of are opposites. The CBD helps dampen down some of that full effect of THC, allowing for some of that effect to go through, but hopefully helping to kind of manage any future downside. Again, all THC all the time in medical use is often, it can be helpful for certain things, but I always try to get a blend of cannabinoids so that we are trying to counteract some of the unwanted effects of THC. So I think it's important to realize that. And just to say that in this kind of natural social experiment that's going on in California, United States, where the social ramifications are certainly outpacing the science, I think that what I'm seeing, especially in the patients who don't have side effects, who are using plant cannabinoids now for years, I'm seeing the brain moving forward. I'm certainly not seeing any detrimental effect, at least for now. Of course, I don't say down the line there won't be something, but I think parents will take this kind of this roll of the dice, so to speak, because a child with uncontrolled, like this little girl in the video for Dr. Lewis, my goodness, your heart breaks for this family. The little girl looks like she's drunk, toddling around, right? And it was a tremendous benefit. And so the question, it still remains though, you know, what happens when you give a 2 or 3-year-old THC over time? Now, I guess we're going to have to see, but we certainly couldn't leave her. He couldn't leave her the way she was, because she was clearly on a downhill path.
And I think that's what we have to remember. We're not talking about neurologically, developmentally normal children. Exactly. And that's, you know, it's the same with in adults. You talk about the same thing. The endocannabinoid system is obviously altered. And that, I think that's a really important point.
I was going to say and kind of reinforce that idea that I have had parents that told me, we have nothing to lose. Those are the words they use, and it hurts. It hurts that we cannot offer anything extra. But certainly, I have had patients starting here in Canada, as Dr. Lewis was mentioning. We mostly had not the purified CBD, but rather a little bit of traces of THC or other tempers, and we have had to lower from 102, that's the best concentration we have ratio of pure CBD, that at least in the past. Now there are coming new ones that are even more purified, but going down from 100 to 2, which will be 50 to 1, to 20 to 1, which proportionally will have more concentration of THC and had better results in behavior and seizure control. So I certainly see a slightly benefit of the in aggregation of the THC, but what it is not known to me, and I guess our colleagues probably agree, is what is the ratio, the best ratio that we know and is safe, and the long term. But the long term, if you don't stop the seizures today, you're not going to see a long term in the future. So really, that's the key point. And what somewhat concerns me, that sometimes parents is the first thing they want to try, and that's something that to me it's I don't know how to handle that situation, because we certainly have other medications that are perhaps better known, the mechanism of action, the side effects, the long-term effect. We feel more comfortable prescribing those, and we have better results. Some patients may be more suitable for other treatment, actually surgical. I'm doing epilepsy surgery here too, and we certainly have we can cure epilepsy that way sometimes, and so it's, but not having the chance to explore those possibilities a little bit, because with this multimedia that it's advocating so much for the use of CBD in everyone, sometimes it's a little bit difficult. So we also need to teach our patient and educate that there is a particular patient that will benefit, some others will benefit from a different approach, and you need to be open that maybe CBD is not the right option for you. But anyway, so those are comments that I, in my regular practice, struggle with, and that it's great to hear my colleagues' opinion and how they deal with those situations.
I think that's another interesting point about the epileptic surgery, because that is something that the British Paediatric Neurology Association, for example, here has recommended that patients be trialed as a candidate for epileptic surgery before they're able to try a medical cannabis product, which of course us as a society fundamentally disagree with. But it is interesting to hear those different perspectives. And I don't know if anyone else has any case experience to share with families in those similar situations where they either had to consider surgery or they didn't want to do the surgical option and they chose medical cannabis, and what was the outcome. If anyone has any cases like that, it might be a nice thing to share.
I'll make a quick comment about that. You know, I agree with Dr. Appendino, right? Epilepsy surgery is curative in some cases, and that might be the better option, really depending on the situation. So it speaks to even like one high principle here is that, you know, we need practitioners who really understand epilepsy well to be open to understanding medical cannabis well, and be open to what medical cannabis can provide, even if we don't have all the data for medical cannabis now. So I think I go as far as to say it's the duty of every single pediatric epileptologist to get their act together and learn about this stuff. And if you're not, then what are you doing? Like I'm okay to actually say that, given that we have such strong case reports and evidence that shows that medical cannabis works for epilepsy. Epilepsy is an on-off phenomenon. You're having seizures or you're not having seizures. So if you give somebody something and their seizures stop, it's hard pressed to say that it wasn't the thing that you gave them. And, you know, so the case I presented is kind of like a critical example there. Coming back full circle to surgery, though, what I often do with my patients that are at the point where we are talking about medical cannabis, they're usually having a significant number of seizures and have already failed some medicines. So the surgical process is extremely important and takes a long time. Because a neurologist recommends, hey, you should be assessed for epilepsy surgery, that doesn't mean that you're ultimately going to have surgery. And that assessment takes a long time. It's resource intensive. There isn't a lot of room. So I always implore my patients to get things going. Let's start with the consultation in the hospital. So that as the epilepsy evolves, because cannabis, has only been shown to be effective in about 30-35% of kids. It's not going to work in everybody, just like our other anti-epilepsy medications. We have to be realistic about that we have the ball rolling for surgery. So if it comes down to, for the case of Quinn, let's just say, if it hit the 8-9 month mark, and I actually had sent her to be assessed for surgery. If we hadn't had that going and she hadn't responded to cannabis, now I've lost 9 months of developmental time of the brain to which she potentially could have been amenable to surgery. So I always tell families, both things need to happen in parallel. And I think that's the way that we should also look at cannabis. So coming back, my last comment here is about the BPNA. I don't agree that we should have surgery first and then cannabis after. That sounds ridiculous to me. They should be happening in parallel with each other, just like you would do with another anti-epilepsy drug. You'd be doing it in parallel. Why is cannabis different? It's an anti-epilepsy drug at this point in time. So I'll kind of leave it there.
That's a great response.
And I agree, Dr. Evans.
This is a great discussion. I'm just going to, there's been a few questions that have been voted to the top, so I'm going to let you guys answer these. The first one is from Robert Seeley, and he asks, there has been discussion that the introduction of exogenous cannabinoids prior to full development of the ECS may alter this maturation process. I understand that this may be more of a factor with THC, but do we know if the use of CBD in pediatrics is an issue in this regard? And we've answered some of this, but would anyone like to tackle this directly?
I'll just mention here, I don't know if we understand that THC is more of a factor here. Like I'm not, maybe Robert, if you have papers that, dispose this, present this. Again, coming back to what Dr. Goldstein said, we do know that exposure and developmental brain to high amounts of THC, these are recreational trials, has resulted in structural changes of the brain, changes in mood, changes in behavior, and changes in cognition decades out. Okay, we've established that. That is very clear. But that's high amounts of THC. And I think any kind of homeostatic system where you just hammered it with one side of the coin or one side of the equation, you're for sure going to result in a developmental problem. I think that's theoretically makes a lot of sense. But I'm not so certain we have strong concrete evidence that shows that THC is a factor and CBD is not, or CBDA is not, or CBD, if we just gave CBD all the time, like what are we doing? We don't know what we're doing with CBD all the time either. So it is interesting how THC gets vilified here. And I think that's steeped in its stigma in the past. And I think a lot of people are talking without actually evidence to support what that is. So I don't know. I think again, coming back to Dr. Goldstein's points and some of the other points that have been made by Dr. Hailey and also Dr. Appendino is it is a trade-off in the end. Exposing a developmental brain to any kind of exogenous compound, you have to weigh that against what's currently going on. And this is why you need experts who understand the wholeness of the condition to know what happens to these kids 4 years later. And then they can properly advise the families to weigh that benefit or risk. And there's always going to be a risk. It's really unfortunate. And, so I don't know. I'll turn this over to my colleagues here to see if they have other answers.
Jane, do you have anything? Or, oh, sorry, Bonni. Yeah,
I was just going to say that, CBD wasn't really readily available until 2013. It's not even 10 years yet. So there is still this lingering question. But I think my colleagues would agree that when we see success with CBD, it looks really good. And the children are moving forward developmentally with better motor skills, learning to read and write and so on. And that is just really a factor of stopping the seizures, right? And in children with autism, it's a factor of helping multiple things, the anxiety, the self-injurious behavior, the emotional outbursts, and getting them to focus a little bit. So clearly, and we know the endocannabinoid system controls many of the things. We know that it's intrinsic to an inhibitory effect in the brain to help dampen down that over-excitation of the brain that leads to these conditions. And again, the trade-off is there, but I suspect that when we're 20 years out, so from 2013, 20 years ahead, I suspect that we'll be able to look back and say that overall the benefits outweigh the risks. I really do believe that because I do think that in the past 8 years or so, we probably would have seen if there was any kind of devastating consequences. I really do think that we would have seen that. And I think that when we look at the other drugs being used, so the typical anti-epileptics that are being used, like drugs like clobazam and valproic acid and all of these, I don't know that they have, I mean, certainly if they're effective and working well and the child is now seizure-free or close to seizure-free, you can see some very normal development. But again, if we're not addressing the endocannabinoid system, one wonders when a child is taking those drugs and still lagging behind, are we leaving them in a deficiency state? And I do wonder about that sometimes.
That's
One
actually really interesting. Oh, so I was just going to say,
Sure.
before you cut in, Evan, I was just going to say that actually addresses partially one of the questions from that's getting upvoted in the chat. So this comes from a parent of a child with epilepsy who's seen their child be extremely ill on AEDs and steroids and still have hundreds of seizures. On prescribed medical cannabis, his life has changed. He takes CBD and THC. He's learning and happy and has good quality of life. And she finds it hard to understand why some doctors feel AEDs, which often don't work and give horrible side effects, are better than medical cannabis products. Of course, some of it comes down to what is licensed as a medicine and what is not, but it is a really interesting point, I think, Bonni, that you bring up about are we leaving, the endocannabinoid system unaddressed with the conventional drugs? And we just don't know is the answer.
One thing I was just going to say, and then I'll toss it over to you for that question, because it comes back to what Dr. Goldstein was saying, is looking just at the, again, I'm just using the case I present as an example, but I have others. The normalization of the EEG, right?
Yeah.
I know if that EEG, so it's not the seizures that you really want to control. To be honest, if you want the brain to develop normally, it's the inter-seizure activity. People who are having very frequent seizures have very abnormal activity in between, which doesn't allow the brain to develop. That's the problem. So in the normalization of an EEG, from the addition of cannabinoids in some cases, shows that we're actually improving the health of the brain, because you're clearly improving the electrical health of the brain, right? So it's just kind of a point there. If we need objective evidence, that's a place to go. So really, what does this whole, just to kind of belabor the point, the THC thing I think we're talking about here is we need better studies that are looking at this so we can answer this question accordingly using more objective data, like high signal that's coming from kind of some of the cases presented here. And I'll turn the question over to you then, Jay.
I was just going to say we have an extraordinary situation in Canada because everything is completely legal. The quality of all the cannabis that's available is excellent and federally controlled. There are probably close to 600 licensed providers here. These are the providers that require medical document and will deliver the medical cannabis to the patient's home. But it's an extraordinarily conservative country. The Canadian Paediatric Society has never said anything positive about cannabis ever, and it's interesting. The support comes from my pediatric colleagues, the neurologists and the psychiatrists at BC Children's Hospital. But it's an extraordinarily conservative country overall.
And how do you find that working in that kind of environment? Was that a barrier to you prescribing?
No, because I just decided to do it myself.
Yeah.
I started out with an organization that fell apart, and I decided that I never wanted to be beholden to anyone else at this stage in my life. And so I became my own secretary, and I communicate regularly with the patients because they're all individual, and I'm just doing it myself.
Mm-hmm. And it is really interesting, even as an adult prescriber in Canada, before I came to the UK, it was quite conservative. More and more of my colleagues started sending me patients who were initially quite skeptical, but it took quite a few years actually. And so still some, you know, of my colleagues thought it was very, very odd. And that's for adults. So it is a funny thing in Canada.
Very much so.
I'm going to go back to Bonni for this one because Bonni, the CBDA and the THCA that you are using in your practice, are you using distillates and you're adding them, or is that how you're using those products?
They're all whole plant. In general, I'm not a huge fan of isolates. I do feel that my patients seem to do, in general, my patients seem to do better on whole plant cannabis. Here and there, we use isolates for particular cases. I have a few teenagers that get drug tested because they're in sports, or one young man was in like a ROTC kind, which is like a military high school kind of thing, and they benefit from CBD isolate or CBDA isolate. But in general, I try to stick with whole plant. I find that it just seems to work better. Interestingly, there's a company that started making isolates of some of the more rare cannabinoids like CBDV, THCV, and so on. And if a child's already on a regimen of whole plant, then I don't mind adding in an isolate. And in a way, it's actually quite helpful to see if it's that particular compound or something else that might be in the mix. So you know, but it can get tricky because sometimes we say, oh, the CBD is helping, but who knows? It might be 5 different things in the product, or it might be not even the CBD. It might be the linalool or the beta caryophyllene, or, you know, the teeny tiny amount of THC that's in there may be stopping the seizures at this very tiny dose. So who knows? And that, I think that was one of the hardest things for me when I was, you know, came out of my pediatric practice where I did pediatric ER for many years. You have a lot of control over the drugs that you're giving. And then in this world, it's kind of like, here's this bottle, and I know about 10 of the compounds that are in there, but not everything else. There's this reluctance to give up that control that you have, especially if you're, you know, like your due diligence and you're really trying very much to understand all of this. But at some point you have to kind of, as long as it's a tested product, you know, there's no pesticides and solvents and so on, you have to start somewhere. And I just don't find that isolates are as effective. But I just do want to make a comment about Epidiolex, if I could. I do have families that cannot afford the very high cost, because some kids are being prescribed what they call off-label. Maybe they don't have Dravet. In the United States, it's Dravet, Lennox-Gastaut, and then tuberous sclerosis. I don't know in Canada if it's the same conditions, however, or in the UK. But some families are combining whole plant with the Epidiolex. Like, so let's say the child, whatever the dose is, 50% of each. It helps reduce the financial burden. It allows for that high dose CBD with some standardized medicine. So it doesn't have to be one or the other. It can be both for some families.
That's really interesting. Does anyone else from the panel have any patients who do a combination of Epidiolex and whole plant? Because that's very interesting to me.
So not Epidiolex, because Epidiolex is completely unaffordable in Canada. So GW Pharma has not come into Canada. They're not going to come in anytime soon, probably. The market's just not here, probably. But we have other purified products. So yeah, that's exactly what I do. That's part of my phase protocols, is I use the purified, I kind of layer things on. So I use the purified product as a foundation and then build on top of that.
Very cool. Thank you. JP, any thoughts on that kind of layered approach? What do you find is most useful in your practice?
So patients of mine, the same as Dr. Evans mentioned, so Epidiolex is not available in Canada. You have to import. It's way too expensive. And even using the available oils in the market that are legally obtainable for a 30 kilograms patient that has Lennox-Gastaut and needs 20 milligram per kilo day of CBD, which is the published data, well, the cost of that will be about $800 to $1,000 per month, Canadian dollars. Okay, but that's essentially the cost, minimal cost. It's very expensive for families. It's very expensive. It's not covered by insurance, which is another topic because it's still not a licensed medication. So it's not. It doesn't have a medication number. So it is approved, but it's not the quality of production and monitoring is a little bit different than what it is in pharmaceutical companies. So it's all those caveats. But families, what they do is they combine. The higher the CBD concentration is, the more expensive the medication becomes. So they combine this one that I was talking earlier, 50 to 1 with a 20 to 1 or 10 to 1. And they use for just before sleep a little bit of less concentration, so more concentration of THC and so on. And that has been quite effective for behavior mainly, as Dr. Goldstein was mentioning, that many of patients with autism may benefit from that. But we don't have an experience, at least I don't have an experience with patients that are using Epidiolex. Okay. Now, what I found interesting is that certain patients that are not surgical candidates and have genetic etiology very well confirmed, channelopathies, CAGNA1, and for instance, and so on, there seems to be quite responsive to medication. So there is a particular group in which I tend to use it more sooner, if you wish, than because I can see that there are many questions about the combination of many anti-seizure medications and the toxicity long term, and it makes sense. Having more than two combined, that you don't know if it is the side effects of the medication, the continuation of seizures, because if you need so many, 4 to 5, is because the child is still seizing, the underlying genetic etiology that you may have not discovered just yet, but there is, and so on and so forth. So it's a combination of it all. And it's not only the seizure, stopping the seizure, what helps in the development, but also improving all these underlying cascade of events.
And to that point, that's a really good point. I'm sure people are wondering at what point, at what medication number would you consider medical cannabis? Let's say you had a child who was still, having some response, and they were on, let's say, 3 or 4 anti-epileptics. Would you consider adding a 5th, or would you another conventional medication? Or at that point, would you consider cannabis as an option? How do you make those kind of complicated decisions?
Okay, I'm going to go first. I was talking, but so depending on the etiology, if I know the etiology of the disease, for instance, Dravet syndrome, or very well established that these patients are more responsive to cannabis in general, or cannabidiol, I tend to offer it after the second failing medication, and when I'm sure this patient is not a surgical candidate, because it's not focal epilepsy, it's generalized, it's a normal brain MRI, and so on and so forth. But so, I also do ketogenic diet here as the director of the program in the ketogenic diet. So we also tend to use it sooner. So after the second medication and I tend to use stronger medication as my second choice when I'm heading, I know that we are going into that path, valproic acid, topiramate medication that are, I know it's going to have a good impact on the seizure control. And if it doesn't, then I feel more confident to offer either the ketogenic diet if the family is not yet open, because as Dr. Hailey mentioned, a conservative society we have here, sometimes they need time to process the idea. So we start with the ketogenic diet, and then if it fails, then we try the CBD oil. It's that process. Some parents are from the get-go, Dravet syndrome, give me CBD. Okay, wait. So maybe clobazam, okay, I don't know. Well, but because of the expenditure. Parents don't realize how expensive it is for them. So I try to also advocate for their pockets. But usually by the second, third medication, if is failing and I know it's not a surgical candidate, I start talking about alternative treatments that obviously surgical treatment, BNS also could be considered within it. But usually that's my practice. But I don't know, maybe differ from my colleagues.
Anyone else want to share on that point?
Yeah, I'm happy to share. So my perspective above all is harm reduction. So that's the lens I wear when working with patients with cannabis. And so I kind of have thought that they subdivide into three groups. There are individuals who absolutely will not even entertain kind of traditional anti-epileptic drugs and are so set on cannabis, and the families are set on cannabis, and so there's individuals like that. There are kind of on the other extreme, people who are very hesitant about cannabis, but start to ask questions about it and have already tried 2+ medications maybe. And then there's the families in the middle who've tried one medication and now want to go to cannabis, and whether we use cannabis as a second-line agent or not. So there's kind of three categories that I find. So I think on the one extreme, this one's quite easy. Like, I think cannabis for sure should be tried if you've tried multiple medications already and are failing. We use cannabis as a second-line agent. So in my harm reduction model, I provide education. Every patient that comes through my clinic must attend a 1-hour session with me about medical cannabis. I do it as a group session. We talk about it and we go through, it's very detailed. I go through the endocannabinoid system, everything else. So now I can have a conversation with someone on the level where there's some understanding about the actual truth, and we've dispelled misinformation. So that allows me to have a really good conversation with that middle of the road group to say, look, we could try cannabis here if you're very convinced. However, if this is, Dravet syndrome, if this, then maybe that's the right choice given the evidence that's out there. But if this is another condition like absence epilepsy, well, we know there are 3 different medications that have great evidence and are very safe, and we might want to try one of those first. So at least then we're having the same discussion. And then the last group is, okay, we have this group that absolutely doesn't want to. I find that after education and having that similar conversation with those people, 9 out of 10 families, maybe more, will opt to try the traditional anti-epileptic first before cannabis. Now there's that portion that don't. And I think some physicians will be like, no way, I'm not giving cannabis first line. So I don't do that. So what I say, because I know that if somebody is that set on using cannabis in their child, given the conditions in Canada, they're going to go off and do it anyway. They're going to buy it at the local store, because you can do that, and they're going to give it to their child. And for me, that's actually me doing more harm, even though I don't know if cannabis should be done first line. If I know that is going to happen, or at least that thought enters my mind, and from my perspective, my personal practice, that to me is going to result in more harm for that individual child and family. I'd rather be the one putting my neck on the line for this family than them doing it to their child. So I'm okay with that. I know that's a very controversial point. Probably very, very few people would agree with me here, but at least they're under my guidance, my care. I can monitor, I can do it safely. I know what they're getting. And then when it fails, now they have an ally with me. And now they're going to go to that second anti-epileptic medication, which may be a more appropriate choice for that family. But I've at least made that alliance with that family and haven't left them out into the void where they're going to be, it's going to be more harmful in my opinion. So that's kind of the hat I wear. I've really shifted my practice in this direction over the many years that I've been doing this. And again, this is a very personal, deep choice for me. That could be that is controversial, probably, but I'm okay to say that publicly because that's the truth. When it comes down to it.
I think it's a very brave thing to say. I mean, I feel very similar in my adult practice, and I'd love to hear what others on the panels, because I hear some other nodding going on.
Yeah, I don't think it's controversial. I think it's compassionate and kind and caring. And I wish I could clone you and put you in every pediatric hospital. It is, we have this, the idea of someone's child having seizures and also autism, or really any other medical condition, is, when you think of it, ultimately is horrific for all of us. It's horrible. we wouldn't wish this on our worst enemy. These families tell me, I don't even want to get in the car and drive over to the local grocery store with my child. I'm terrified they're going to have a seizure and aspirate in the car, or in the grocery store going to have a seizure. It changes life for these people, and the quality of life for the family and for the child is just, it can be devastating. And so I think that we have to be here to support those families, even if sometimes we disagree. Now, I think Dr. Hailey and I are in a different situation in that we get referrals because we're not neurologists diagnosing, as I don't know if that's correct, Dr. Hailey, but yeah, she's shaking her head. So I don't diagnose patients. It's after they've kind of been through seeing neurologists, sometimes multiple neurologists, multiple medications, that they end up in my office. And so often I say, like, I see some of the worst cases where literally I've had a patient 21 different medications over 11 years with devastating neurologic deficits and you know, just terrible. On average, in my practice, patients have tried on average 8 different anti-epileptic drugs. And if I let my neurology colleagues correct me if I'm wrong, but pretty much after the third one, the chances of responding are very low. And so I think it's very reasonable after the second or third that you have to start thinking out of the box. And I do think many patients do go through the surgical workup, but also in I think pediatrics a little bit different than adults. It's not, you know, there's a lot of children with syndromes and so on that are not qualified to have, or, you know, they don't meet the criteria for surgery. And so I think one of the things that Dr. Lewis is pointing out is that you have to have a real conversation and say, cannabis is not everything that everybody makes out to be. You know, there's all of this media attention. However, it should be in the list of options for every family, and it should not be last resort. I don't think it's acceptable for someone to try 8 medications and then try cannabis. You've lost brain cells at that point. You've lost time, not in every case, but in many cases. And so I think Dr. Lewis's approach is excellent in that you educate, you share your knowledge, your medical expertise, and then you help the family make the best decision that they can at that time.
Thank you. Anyone else want to chime in? Yes, Jane. Thank you.
Okay.
We hear you.
The neurologists in British Columbia, most of whom are based at BC British Columbia Children's Hospital, have been very, very supportive. Now, they seem to be limited in the licensed providers, that licensed distributors that they can use, and I don't know what's causing that and what is behind that. But I generally work with them, and that's one of the things that I insist on, is that their neurologist needs to be aware and involved, and so I try to work with them. And that's been reassuring, but I do make sure that whichever neurologist is following the child, that I communicate with that neurologist and he or she knows what I'm doing.
And Jane, that might be very interesting for our colleagues in the UK to hear about, because one of the things here, as I introduced in the beginning, is that there's no pediatric prescribers at all in the UK anymore that are taking new patients. There's only one pediatric neurologist. He is full. So of course, it would be wonderful to have general pediatricians with an interest in this area to start prescribing. And how does that work? How does the shared care work? Do you do the cannabinoids and then they keep track of the epilepsy and the monitoring of the other medications? And how does it work?
I'm supposed to be just the cannabis prescriber, but because I'm a general pediatrician, I end up getting more and more and more involved in their care. And I am learning to say no. I mean, one parent was asking me about, should we see a dietitian? Should we do this? Should we do that? Should we do blood work? And I happen to know that, the patient has a phenomenal pediatrician who's very much in support of everything. And I just said, you know what? I think you should make an appointment with Dr. X because I'm getting too involved. So that's the hardest part, because it's so easy to, for example, parents talking about constipation with their kids. And then I go off on this whole thing about treating the constipation. And then finally it's, no, I shouldn't be doing this. I should just be holding back. But it's hard as a general pediatrician who's treated so many kids with so many conditions over the years, to hold myself back and say no to other things. But I am in constant communication. I mean, I have a cell phone. I have my own cell phone. I'm my own secretary. So anybody can contact me anytime. So that's how I cope with it. But no general pediatrician in British Columbia is interested in doing this because they are all way too busy. And the pediatricians are seen by referral only. They have waiting lists of up to a year. And I don't blame them for not doing this, because it's huge. In my, I have not found anyone who's interested in doing, a general pediatrician in British Columbia who's interested in doing this. And I understand why.
Yes, you really have to have a passion. But I think what it's taught us is, yourself being a general pediatrician, it is possible to do this very well as a general pediatrician when you have the support from the colleagues who are monitoring, for example, I'm sure you have lots of children who still take anti-epileptics. I'm assuming the neurologist would handle those medications, and it's just the communication back and forth. So it can work, because I think here in the UK where we're at is people, some parties are convinced that it cannot work. And, I know that it can. I've seen that it can in Canada, even though it's not always perfect, but it's nice to see that example. So thank you. Thank you for all the work that you're doing.
You're welcome.
It really is the model, I think. I think that, it's too overwhelming for some of the specialists to really know this stuff in a lot of depth. So that's what I do. I do a lot of peer support and combined care to, to have that individual go off and be able to prescribe cannabis. Like when it comes down to it, should the pediatric neurologist be the one prescribing cannabis for autism? Most pediatric neurologists in Canada don't work primarily with autism. So that doesn't make a whole lot of sense to me. So I think we have to be very serious about a model like that. And it has to come from the current cannabis champions to start educating and creating other champions, and have this kind of, effect downstream where other people are picking up the reins here and becoming knowledgeable in this area. And I think pediatricians are a great group. It's tough. They are busy. I know that, but there for sure are some pediatricians, especially the younger ones who are coming out of training, who are probably very interested in exploring this. So, that's the model in Canada, I think, now that we really have to work towards. And I think I would, implore other kind of countries and other kind of areas where there are like the few people out there who understand this stuff to start thinking about ways in which we can do this, because it's not going away. That's for sure.
No.
Right?
No, absolutely. And I just had another question here. Okay, I'm just going through my questions. Bear with me. I think I've got to. Someone's asked about THCA. I know we've already touched on it briefly. Bonni, did you want to maybe say something about when you might add on THCA versus CBDA? For example, I know people are really interested in those additional minor cannabinoids.
Well, so something to think about, what is THCA and CBDA? So they're the raw forms that we call the acid forms. So they haven't been heated up. And so they're coming from the raw plant and turned into usually extracts or tinctures. And I usually recommend people keep them in the refrigerator in a dark bottle or wrapped up bottle so they're not exposed to heat and light. There was a study that came out just earlier this year or last year on THCA showing some anticonvulsant activity in animals. So we now have some, and I think the first study came out in 1979 that showed that there was some anticonvulsant activity with THCA. There's no question that the acid forms are more bioavailable to the body, which means that we absorb them better. They're less lipophilic, they're more water soluble, so we absorb them better, meaning you may not have to take such a high dose. I have, in my practice, I usually start, CBD has the most evidence, so I usually start with CBD first. However, in some cases, I will, especially where there's dual diagnosis or behavior issues, I do find that THC can help THCA. THCA has a little bit of THC in it, and for the most, and you have to be careful because some products are half and half, which is not what I usually recommend. Usually I'd like a dominant, like usually a 20-to-1 ratio or higher of THCA to THC. And you know, it's a good question. When do you use this? So if a family struggles with financial cost of CBD, then this can be a very nice option. If someone doesn't respond to CBD, THCA can be a very nice option in combination with CBD. So it's, again, case by case, but in general, the way my methodology is I'll usually start with high ratio CBD products, sometimes add in some THC, which will change that ratio. And again, I don't know that there's any one particular ratio for one disease. Each child is unique in the way they respond, even though they check off the Dravet box or the Lennox-Gastaut box. And then I will consider adding THCA. I have patients who take 4, 5, 6 different cannabinoid oils with excellent results. There's a little girl I take care of that she has a very rare genetic syndrome at age 10. She was having, her EEG was a complete and utter mess, similar to the EEG that Dr. Lewis showed. And she right now is on 8 different products, all in very tiny amounts. Now, how did we get there? That's over 7 years of treatment, little by little, with greater than 90% reduction of seizures. And she went from a 10-year-old who had the same development as like a 3-month-old to now crawling around, using a sippy cup, feeding herself with a spoon, using an iPad, clearly engaging with the people around her, whereas before she didn't do any of that. And so it's not just, it may not be one product, it may need to be a whole bunch, including the CBDA or THCA, sometimes they add in. And this is why I feel so strongly that we have to allow for all of these products to exist on the market and do our best to tell the parents, I'm going to help you. Please don't add things, take things away, or change things without discussing it with me and managing. And I think that's why we're all so busy, is because this is not simple. Oh, here's some CBD and see you later. It is managing children very closely. And I think the neurologists who are the ones diagnosing the patients and also dealing with the pharmaceuticals and all these other treatments, and ketogenic diet and so on. I don't know how, isn't like, I applaud the 2 doctors here who are neurologists, because I don't know how you learn so much about cannabis and then add it on top. It's a specialty in and of itself, right? So, but that's, THCA is definitely something that you can try initially. You can add it in after with CBD, whether CBD works or not. And the best thing though is you have to be methodical in your approach, and there's no way to guess a response. I'm pretty sure it's, you know, we make educated guesses all the time, but there really is no way to guess who's going to be a responder and who isn't.
And I think it's a very humbling experience in medicine. It was the first medication I've used like this, and that we use a scientific method, as I always tell my patients, and we try things systematically, but we don't know what is going to be the best product. Sometimes we get 2 products, 3 products before we find the right one. We have to add them together, as you said, Bonni. And it's a very individual medicine. It really truly is a personalized medicine. And I think that is difficult, it's difficult in adult medicine, let alone in pediatric medicine. But I don't think because it's difficult, we should let it be a barrier to these children who really do benefit so greatly from it. Okay, I'm just going to look at the questions. Yes.
Okay, one of the things I was going to say with regard to education is, and the safety of THC and CBD is, I talk about opiates, and I talk about the receptors in the brainstem that respond to opiates. And I describe it literally like this. Your brainstem, where all the opioid receptors are, go down, 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 and your brainstem, which controls all those other things, just sucks you up and pulls you down, and you're dead. And then I tell parents there are zero receptors for cannabis in the brainstem, zero, so that you really can't, you might have a bad experience, but you won't die from it. And I'm amazed how many parents don't know that.
That's incredible that that people still don't know that. And I've run into the same thing.
Mm-hmm.
There's a lot of misinformation. Thank you. I'm seeing a lot of, I've seen some comments on the chat as well, which just, showing us how much we need these conversations here in the UK, because lots of parents here are saying they just cannot get access in the UK, which is why we're all here. So hopefully it will get better. Okay. Let's see. There is actually another colleague here saying, Robert Seeley, hi Robert, saying that the pediatric neurologist in Vancouver objecting to the use of CBD because the patient had previous suicidal ideation was concerned that CBD would increase this risk. So of course, this just really shows that even, our colleagues in medicine obviously have a lot of misunderstanding about, as Robert is trying to point out from his question, that CBD would have potential for suicidal ideation, not really understanding, of course, that that's completely erroneous. They're thinking more about THC, and even then it's a very small percentage of people who you'd have to really worry about that with. So thank you, Robert, for pointing that out. Sounds like you guys need to chat. Is there anyone else who would just like to share any additional cases that really are front of mind to them in their practice?
Not really case, but some other comments about how long you try CBD until you say, okay, fine, it doesn't respond to. Okay, because sometimes that also is a topic of how long.
Yeah.
Here in our hospital, we have a protocol that we start the patient with gradual increases until we reach 10 to 20 milligrams per kilo per day of CBD. And we have to monitor every month this patient with blood work because of the liver function. And then by 3 months of being on as much tolerable dose the patient could go, or if the seizure responded sooner, then we stay in that dose. Then we try for 3 months, and after 3 months, if it hasn't responded, then we give up on the CBD, sort of speak, if there has been no changes on the seizures. And we are talking about patients that have at least daily, if not weekly seizures, so you can assess in that short time, mainly because of the economical impact that these have in patients. If families sometimes decide to try a little bit longer because they saw some benefits and they would like to try a little bit more, then that is up to the family and the neurologist who is treating that patient. But we do have a protocol in order to not make insisting in something that is not working, and we move on to a different approach. So I don't know what the others' experience is. Yeah.
And is that with trying different percentages of like a 1 to 100, then you move to a 1 to 50, and then you move to a 1 to 20?
Yeah, we try always start with a higher percentage, and I probably is what Dr. Hailey was referring to, the neurologist in UBC. There is in Canada, we have published kind of guidelines for the use of CBD, and in those guidelines where the availability of trials were back then when it was published was mainly on the 50 to 1. So the 50 to 1 was the closest to the Epidiolex. So that's why we kind of most of our neurologists probably advocate for the use of 50 to 1 to start with, and they are very hesitant to move from those ratio. But we try usually to start 50 to 1, and if the family, as I mentioned before, economically they would like to change, we change along the way. But we try at least a solid 3 months of a good dose, at least 10 milligram per kilo of CBD or higher, unless the patient has responded so nicely that sometime with 3 milligram per kilo may be enough. Per day, I mean, and that's where we stay. But usually we try at least 10 milligram per kilo, if not 20, in a solid 3-month trial, if side effects permit as well.
I agree. I agree that
Yeah.
I usually give a patient 3 to 6 months and multiple products and multiple cannabinoids to try. In my practice, people engage me for a year at a time. So I say we have a year to try to sort it out, but I will tell you the truth if I feel that your child is a non-responder, so we don't lose any more time. And it's always disappointing to have that conversation, but I have that conversation in that some cannabis doesn't work for everybody. Certainly not. I think it's also important to point out that parents need to come in. The conversation about expectations should be in the beginning, that this is not magic. This is just another medicine. We have to treat it as such, and that there are some side effects. I mean, I've had patients with CBD have decreased appetite. I've had some patients have diarrhea. I've had some patients have other side effects. In general, though, I have found that and this is where it becomes a little bit different than the pharmaceutical medications, is that by manipulating the dosing, the product, or the timing, you can often alleviate those side effects for that patient. And I just want to make one other point. And children, from when they're born to when they're in their late 20s or something, I mean, they're constantly changing, developing, growing. That's what children do. And I also tell people in the beginning that we may achieve seizure freedom or close to, but as the child grows and develops, you have to remember their brain is growing and developing and also may change. And I wanted to ask my colleagues what they thought about this. I kind of feel like treating children is like treating a moving target. You may get somewhere for a few years and then puberty hits, and everything just, goes to what. So I'd like to see what my other colleagues say about how they deal with that, because sometimes you can get very nice results and then you lose some of the medicinal benefits. And I'm always curious to know if others think it's because of the developmental changes, the progression of the brain and the growth of the brain and so on.
I would say you're bang on there, and it's not just with cannabis. We see this phenomenon with any anti-epileptic drug. You see it, like you can have a very well-controlled child on, I don't know, clobazam, it's doing great, and then out of nowhere, there's 3 years later, boom, there's an explosive onset and it comes out of the blue, and then you can't get a hold of the seizures. I'm sure Dr. Appendino can agree with me here. Tons of that, and it probably speaks to exactly what you're saying there, Bonni. It's certainly the developing brain, whether it's hormonal related or not. The brain is pruning itself all for 25 years, right? So it's going to change, and that we see it with epilepsy. It's quite common.
Yeah, a medication that may not work when they were younger, they may work later as well. So that's another point for the development, the expression of protein, different maturation of channels. It's a process, always developing. I think Dr. Hailey wanted to say something. Sorry, I cut you off.
I just wanted to say that as a general pediatrician who has been in practice for over 30 years, I've watched so many children grow up, and the initial expectations told to them by the neurologist at birth have been 100% wrong. And I've also seen a maturity develop over the years. And there is going through puberty, and there is going through maturity. And so these kids mature as they grow. And so, Bonni, you're right. It is like dealing with a moving target. And I've learned a great deal on participating in this. But yes, it is. And that this is making me rethink how I deal with patients now when things seem to work well and then they don't.
Mm-hmm. Thank you. Well, I'm going to start wrapping it up now because we're almost at our time. And I just really want to thank all of you so much. And also, I have Dr. Nathan Hassan on the chat, who is our only prescribing medical cannabis pediatric neurologist, pediatrician here in the UK. And so I just really want to salute you and thank you. And he has just let me know on the chat that he will be starting to see more patients, taking on even more patients to help us with this bottleneck situation that we have. So thank you so much to him. And I hope you know you have lots of support. We need to get you on here next. So thank you so much to Dr. Jane Hailey, Dr. Bonni Goldstein, Dr. Evan Lewis, Dr. JP Appendino, and thank you so much for everyone who attended. And we really hope this is going to stimulate more conversation in the UK and hopefully other places too. And you know, we just really want, at the end of the day, the best for all of our patients and for all of the options to be available to them. And that's really the reason we've all gone into medicine. So thank you so much for giving us your time on this Monday afternoon for some people, evening for some people, and I'll just sign off from there. Thank you so much.